Hello and welcome to the Two View, the cutting edge educational and interactive show for PAs and nurse practitioners in emergency medicine and urgent care. This is our favorite month of the year, the second month of the year. And maybe you're tuning in for the first time because you're really feeling the hype around the 2/22/22 date. So we're going to reintroduce ourselves. My name is Mike Sharma. I started my PA career in the U.S. Army, including a deployment to Afghanistan. Now I practice emergency and urgent care medicine in Dallas, Texas. With me is my co-host, Martha Roberts.
Hi, Mike. I'm Martha Roberts, and I am an adult and pediatric nurse practitioner. I work at Zuckerberg San Francisco General Hospital in San Francisco, California, in the emergency department. I'm also an assistant professor where I run the pediatrics department at Samuel Merritt University here in Sacramento.
Martha and I are both faculty educators at the original emergency medicine boot camp in Las Vegas, Nevada, under course co-directors Dr. Rick Bucata and Dr. Diane Burbaumer. This is run overall by the Center for Medical Education. You can find them at www.ccme.org.
So since January 2021, Mike and I have been discussing the latest in emergency medicine and urgent care from the perspective of the PA and the nurse practitioner. Two views on the same topics, occasionally an oblique view from a special guest. It's been awesome having these guests from around the world, emergency medicine education, giving us really just great information. So thank you for all of those special guests. We actually have one this year at the end of the podcast, and I'm going to let Mike tell you about that in a minute.
Okay. Well, speaking of the latest in EM and urgent care, let's get into today's topics. I'm really happy for Martha's sake that I'm the one with the mysterious ailment this month. We'll start by talking about urticaria in its different forms and some mimics and how you can treat that. Then a topic that's a real pain in the butt for patients and clinicians alike, vaginal and rectal foreign bodies.
Yeah, Mike, I thought you were about to say one that was your problem this month was going to be a rectal foreign body. That would have been
just to be clear,
fun.
The urticaria is my problem. Yes,
Okay,
and not the other one.
All right. So we have a couple of pain in the pelvic area issues, right? So we're going to switch ends at the end and basically go to the mental and the heart. And we're going to talk to a really wonderful guy named Kenny. So Mike, tell us a little bit about Kenny.
Kenny Mintz was my first boss as a PA. He is a retired Army colonel, and he's going to walk coast to coast across the United States of America coming up in April to raise some funds for causes near to his heart, pancreatic cancer, and soldiers here. Okay, we're also going to talk about mushrooms and some COVID updates. We've got a lot of important stuff you're going to see this week in the emergency department. Let's dive right in. I've always had a special place in my heart for my itchy patients that come to the ED because they've got an itchy rash that won't quit. I tell them, in all sincerity, I'd rather be in pain than be itchy. And I got to personally test that theory out this past month. I got some sort of an upper respiratory infection last month. My poor nostrils will attest. I tested COVID negative several times in every which way you could test somebody for COVID. But while I was dealing with that upper respiratory infection, I got hives all over my body. My hands were so swollen, I couldn't even close them fully. I had to pull my wedding ring off before it got too bad. I'm wearing kind of a fakey one of these silicone rings still because I'm just kind of terrified of putting it back on, to be honest. And I couldn't sleep because I was scratching myself. It was super rough. Thankfully, I'm getting better, but I'm not out of the woods yet. I'm still taking medications to control my symptoms weeks after the onset of my symptoms. Let's talk about the urticaria that I had, and that there's more that we can do in the ED than just reaching for the diphenhydramine.
Yeah, first, Mike, I want everyone to be precise with their terms. And, I get a little bit bossy about this, but urticaria is a raised red itchy rash, and it's different from pruritus, which is just the sensation of itching, right? That's kind of more of a subjective thing. It comes from mast cells and basophils in the superficial epidermis. When these cells are activated, it leads to the release of things like histamine and other chemicals that cause vasodilation. It's different from angioedema, which has to do with mast cells activating deeper in the dermis and the subcutaneous issues, and it causes other problems. Now, about 1 in 5 people will be affected with urticaria in some degree in their lives, and it happens in little kids all the way up to older adults. And sometimes we're going to see what we're going to see is really not just the first line treatments. we want to take some of these next steps. What are they going to be?
Right. Well, it's tempting to think of urticaria as some sort of allergic reaction, but that's just one of the reasons you can get urticaria. Different kinds of infections, whether it's from viruses, bacteria, or even parasites, can cause urticaria. One common bacterial infection is mycoplasma. And that is one way that you can have urticaria that does not resolve to antihistamines. Thankfully, it does respond to everyone's favorite drug, azithromycin, right? So finally, another use for the Z-Pak. I'm so happy to find that out, okay? Hepatitis A, B, and C can also cause urticaria, and they can even happen before you see kind of like the jaundice and other things we usually associate with hepatitis. Different medications, relaxants, some anesthesia agents that we use in muscle relaxation, paralytics like vecuronium, succinylcholine, those can cause urticaria. IV contrast, NSAIDs. How about for all you sushi and fish lovers out there, scombroid syndrome can be implicated in urticaria. Even certain physical stimuli, heat, pressure, cold, vibration, all of these things can be triggers for urticaria.
The wind. If I blow on you, you get urticaria.
I mean, that could be a pressure vibration thing. So yeah, I guess. Like
Certainly.
water, like regular water can even cause urticaria. Latex, I bet. Yeah. So anyways, lots of things.
All right. I think it's also important to understand that there are a lot of mimics to urticaria. Urticaria can happen with vasculitis, autoimmune diseases like lupus, rheumatoid arthritis, and other autoimmune diseases. And like you always say, Mike, it could be cancer. So
Always could be cancer. Yes.
certain malignancies can cause urticaria. But let's talk about the physical exam. As much as you all know that I love this, the hallmark of urticaria is that the lesions come and then they go away within 24 hours. And even sometimes during the course of an emergency department stay, there should be no residual lesions or pain to the area. If there are, that can be a clue that maybe this is more of a vasculitis or something else.
In an otherwise well-appearing patient presenting solely for the urticaria, a big lab workup in the ED or especially in the urgent care is not really indicated. There could be other things that can be helpful down the road as an outpatient, like maybe a CBC, a CMP, LFTs. But if you weren't already ordering these things for another reason in the ED, you probably shouldn't be ordering them just for the urticaria. How about treatment? Sometimes patients come to us without having done anything, which is kind of easy to treat those. But sometimes they've already tried a few different things. And now we got to figure out, well, what else do we do beyond just saying, hey, we can't help you? The goal here is to relieve the itching in the short term. Thankfully, 2/3 of new onset urticaria will be self-limited and resolve on its own and not progress to chronic urticaria, which is defined as over 6 weeks of urticaria.
How many times have we said urticaria in this podcast? It's
Urticaria. There you go. Three
kind
more.
of a fun word. All right. So the first thing to try are antihistamines. And I think that it's tempting for us to reach for the Benadryl, hydralazine. These first generation antihistamines have issues. Obviously, the sedating aspect can be a problem for people who need to stay awake, but we're talking about anticholinergic side effects, things like urinary retention, constipation, and people already taking medications that can cause anticholinergic effects. These effects can be not great for patients. So I feel kind of silly telling folks to take over-the-counter medications for things they came to the ED for, but come on. There has to be sometimes that, you wish people had done this. But again, we're very kind and gracious, and we help patients along. There's no hard evidence that over-the-counter second-generation antihistamines are any less effective for urticaria than first-generation antihistamines. These second-generation antihistamines like cetirizine, loratadine, and fexofenadine are non-sedating, but they are usually less sedating. So there are also other special versions of these second-generation drugs, like levocetirizine and desloratadine. These medications basically produce the same antihistamine effect at half the dose. So if people are having good relief with regular versions of these medications, but there are some side effects that you don't like, maybe you can try these drugs instead. So don't write off one drug over another here. So for a class.
Something else that can be lacking in terms of large studies, but does have some backing in some smaller studies, is an H2 antihistamine. So we think of these as reflux medications for esophageal reflux or heartburn. So these are H2 receptor inhibitors, H2RI drugs, but at their heart, chemically, they're antihistamines. These are drugs like famotidine, cimetidine, and so these are drugs you can add on to using the H1 antihistamine, like all the other ones we just mentioned, the first and second generation. How about glucocorticoids, steroids? There have been some small trials in these acute urticarial patients here that suggest that steroids don't additionally cause a better or faster resolution of urticaria than antihistamines on their own. If someone has not yet maxed out therapy on a combination of H1 and H2 antihistamines, then I wouldn't reach for the steroids then. But if they've already kind of like tried different combinations of H1 and H2s, then maybe that's a good time to go for the steroids. For the steroids there, we'd be talking about prednisone and then prednisolone in our younger patients, because it's, the liquid suspension here. You'd want to max out at about 60 milligrams at the course of, speaking of pediatric patients, hello, Andrew, my buddy Andrew here. Come on the podcast, Andrew. We're going to have a little guest host here. Who do you think is on? This is Andrew. Hey,
one of your 9 children. And, it's funny, although we're being interrupted, I got to tell you, everybody who's been working from home certainly knows that these issues occur. But it just shows that we are real people too, Mike. We are real people. So
yes, I have to be, my batteries have to be changed like everybody else, right? Just like all the other real people out there.
Yeah, but actually, I also wanted to say, kids in urticaria is such a different animal. I feel like when we see these patients, myself, having to be a ped specialist, this is sometimes a little more difficult, right? So I just think, regardless if we're giving prednisone or prednisolone or trying to figure out what's wrong with this kid, or the kid's itching or not itching, it's heavy, all right, because you're dealing with the kid and the parent. And I think we could do a whole segment just on pediatric urticaria. But I do want you to sort of finish telling us a little bit more about some of these other treatments.
Right. So real quick, the prednisone, either way, you're kind of maxing out at 60 milligrams a day. Some guidelines say taper over 5 to 7 days, but honestly, going hard 60 milligrams every day for 5 days, depending on weight-based dosing, et cetera, is just as good as tapering, and probably even better. You might have heard that there are IV formulations of some of these second-generation antihistamines. There's even IV Benadryl/diphenhydramine, IV hydroxyzine. Again, none of these drugs has been shown to work better for pure urticaria than the oral versions here. So it sounds like a good idea for someone. Hey, well, they've got a rash and they're vomiting. Well, why don't I give them the IV version of this? Or wouldn't it work faster or better? And none of those things is really the case. By the way, if your patient with really bad urticaria is also vomiting, I would want to take a second look at that patient and make sure they're not in anaphylaxis, which is a totally different animal than pure urticaria. And we're talking about using epinephrine as our first line drug. Yes, we give things like fluids and antihistamines and steroids to these patients' anaphylaxis here, but really there is no replacement for epinephrine early and repeating it often if you need to for someone you think is an anaphylaxis.
Yeah, and some of actually these really bad cases of urticaria where maybe you're not so sure and you really just want to be self-protecting here. I mean, I've given it lots of times to what I would call a stable, actually that's kind of a dangerous word to use, a concerning patient that's still breathing and, interacting with me, but it's like, I don't want this to progress any further.
Totally.
So, yeah. So how about the dose, okay, of the antihistamines themselves? Because urticaria usually self-resolves, there aren't many studies specifically on acute urticaria and updosing on these antihistamines. However, there is good safety data in updosing second-generation antihistamines in adults and children for chronic spontaneous urticaria. There's no reason why you could not extrapolate that safety data to a person having a short-term urticaria and using these updosed antihistamines for a shorter period of time that were studied. We will have some studies in the show notes that talk about people who have double, tripled, and even quadrupled doses of second-generation antihistamines.
Right. I'm currently on twice daily dosing of loratadine and famotidine, and it's going really well. But I'm still having urticaria weeks after my first day of symptoms. So it's been kind of a journey for me. In short, don't just think of urticaria as an allergic reaction to something. There's lots of different causes. Be aware of different urticaria mimics and how you can kind of pick those out, or there being pain. Lean on your non-sedating PO antihistamines first over your sedating antihistamines or giving IV antihistamines. Add in your H2 receptor inhibitors like famotidine or cimetidine, and maybe consider updosing your second generation antihistamines as an option even before you go for the steroids.
All right. So we're going to go right into now the sort of hot topic of our podcast this month. Now, we took it easy on you with the urticaria, but we're going to lay it on now. This is foreign bodies in the vagina, toxic shock syndrome, and foreign bodies in the rectum. Now, don't turn out. This is going to be, don't tune out. This is going to be a very respectful conversation. We're going to talk about foreign body in the rectum and vagina. In fact, I usually have a few patients a year with this issue. And actually, I was listening to one of Howard Stern's old podcasts was talking about this topic. I was actually trying to listen to Al Michaels' interview, which I eventually found it was really great, by the way, because I used to live in Cincinnati and we know we have Super Bowl coming up. But I wanted to bring to light here on the podcast this important topic in emergency medicine, not on the way Howard Stern talks about these things. But by the way, did you know that Howard Stern's daughter is an NP, a nurse practitioner? I thought that was really interesting. Maybe we could get her on the show. Anyway, this next topic and the case studies are very important. And I feel they're important for a variety of reasons. They're difficult and they are concerning. And we're going to talk really about how we approach that patient and then a little bit about toxic shock as well.
I think when you told me you were going to talk about these topics, I went into toxic shock.
Yeah. So I think, again, this is a tough subject and there's more at play than just something in the orifice. Okay. In fact, I was doing an internet search and I didn't really find too many podcasts about this, at least those that are related to emergency medicine. Other venues, yes, I did find, but I digress. First, I feel there are certain people who mock patients and cases that involve foreign body insertion. There's always one juvenile coworker. Second, clinicians play a crucial role in removing these objects for the patient without judgment or ridicule. And the ER is the place to go for an emergency, okay? Even though this may have been a preventable emergency, right? Maybe it wasn't. Maybe this is an assault, but we'll talk about that later. Sometimes several sensitive things can come up during these conversations. And really what's important here is that you also make sure there's no underlying abuse, mental illness, or other trouble brewing. Or if this was just an act that they did for fun, to feel good, whatever, which people do for their own reasons, that part is not my business. What is my business is letting them know that I'm here to help them and I want to take care of their issue. I also ask safety questions about how it happened in a general and even tone that is more informative and objective than subjective.
I love that. Let's talk about a few cases you may see in the ER and how to approach them. Let's start with vaginal foreign bodies. After you hopefully remove the foreign body successfully, there's always other discussions that kind of follow on, usually things about like, do I do some sort of irrigation or douching of the vagina for kind of like cleanliness and upkeep? Is there and not just as a patient later on, but as the clinician after you remove the foreign body, does a specialist need to be involved and when? Do I try to retrieve the object? Do I need imaging? Are there antibiotics needed? How concerned should I be about toxic shock syndrome? And how do I know if someone actually has it? So we're going to go into all these questions and help you treat this patient as professionally as possible.
Yeah, so let's start with the patient, Kara. She's a 19-year-old female. She comes in for a foul odor in the vagina, and she may be reluctant to tell the triage nurse that she thinks there's a tampon left in her vagina. And so the triage nurse puts her in the fast track in a hallway without a gown.
Yeah, it's pretty classic that these patients are in hallways or they're triaged as ESI level 4 or 5, and they're just left in the waiting room. please educate nursing staff that these pelvic complaints do not belong in the hallway or a waiting room. I can't discharge them from triage, okay? Let's put them into a private room or at least a room with a curtain. And if we have to do something like that, then there's ways we can move patients around. But in the end, this patient's path of discharge, it leads through a private room of some sort. And that curtain room, I mean, I know the pandemic is going on, but I mean, no one wants to talk about this. There's only a curtain separating them and their neighbor here. So best thing, a private room. It's usually a short visit in the room anyways, and they can be pulled out of that private room, kind of musical chairs, as you will, and be put in that hallway bed maybe afterwards, okay? When it's time to go back and discharge instructions, you're going to want to find a private area again, and the hallway is just not the place to do this. So really just be aware of that, and you know, think about if the shoe was on the other foot. You'd want to be in a place that was more private if you had something more sensitive going on with you.
Yeah, Mike, you can say it. Shame on you if you're doing this. Come on, I'm going to ring the shame bell.
Oh, wow.
It's the shame bell.
Is that what that is?
Yeah, it's St. Francis. So
oh, okay, very well.
So let's just say Kara, she's in a room, she's in a gown, we do an exam. The best thing to do is ask all the questions first. Don't ask them these questions while you're doing the pelvic exam, all right? You're not, it's just, you cannot focus on anything except something physically being in your personal space. Like you're not going to answer personal questions while that's occurring. So sit down and talk to your patient before you put that speculum in. You know, once you talk to Kara, you found out that she finished her period 2 weeks ago, and sometimes she puts more than 2 tampons in her vagina during menstrual cycles because it's just so heavy. So this is a great time to kindly tell the patient the right way to use tampons and other feminine products. Maybe she did not get that information as a kid. You don't know. Hell, my mom certainly didn't go through all these details with me about how to put on tampons. I didn't have YouTube. I mean, I don't even know if there's YouTube videos out there about how to put in tampons, but maybe I should research that for you guys. But, you know, I think probably I walked around with a tampon half out of my vagina for my teenage years. But anyway, TMI per usual, I just want this to be a lesson for our listeners that you need to tell people how to do things. That is your job. We constantly say that to you on the show. We talk about, you know, physical exam being important. We talk about teaching your patients. We talk about you taking responsibility, those types of things. That's your job. So tampon insertion, that might be something you need to brush up on. So if you're someone that doesn't know how to do that, i.e. you're a male and have never had to do it, ask a female that you feel close to maybe explain that to you. I'm not going to actually do that on the show today. But very important that, you know, you take these tampons out within 4 to 6 hours, remove it if it feels uncomfortable, seek care if you get a fever, and certainly never have sexual intercourse with a tampon inserted. And gosh, again, never place more than one in there. Okay.
In case you're wondering, there are multiple YouTube videos on how to insert tampons made by several different people. So that's out there for folks if you want to look that up and kind of get that going. How much YouTube learning do we do before certain procedures in the ED? Like, there's been times when I do, like, let me look up YouTube to remind myself about, you know, approaches for different injections and stuff. So yeah, that's also on YouTube, folks. So yeah. By the way, did we have Dave and Ricky put a like a parental guidance warning on the show beforehand? We probably should do that in post.
I'm not sure if this is for kids or not for kids. Okay, so I had to explain to Kara how to use tampons. All right, I took a really good history. You know, I sort of took it to the next level about her heavy menstrual cycles, and in the end, she did end up following up with GYN and put her on some birth control. So, but let's get back to the foreign body in the vagina. After all this questioning, I did her pelvic exam, like I said, and again, if you're not doing the basics of a pelvic exam correctly with a chaperone and, you know, comfort level and all those things, again, shame on you. I ring the shame bell, ringing the shame bell today a lot. So I just wanted to say that after I took a look in there, I saw that there were not just one, but there were 2 tampons, and they were sort of like these smaller tampons that some women just lose up in there. They're very small for like a light flow. And then I removed those, no problem, visualized them, and no material was left behind. I mean, they're not going past the cervix. You know, a lot of patients think, hey, is this like up in my brain now? No, it's not going past this cervix. Okay. But I did insert about 50 to 100 mLs of room temperature normal saline to clean around the cervix because there just was some buildup there. I didn't take a sample or a specimen, wasn't needed. And that was it for Kara. I told her to follow up with GYN. And to only put in one tampon, consider using super tampons. We had a whole discussion about this, but she was afebrile and she didn't really have any pain. So toxic shock syndrome or another issue really wasn't on my agenda today with her, but I did counsel her on potentially this in the future. Now, before Mike, you dive into toxic shock syndrome, I want you really to ask yourself, and audience to ask yourself, how often are you getting vaginal samples for a female patient with sepsis-like symptoms or flu-like symptoms without an obvious source? Meaning, when you have this really sick patient, you're getting pan cultures, you're getting blood cultures, you're also getting X-rays, urinalysis, urine culture. But hey, I didn't really think to myself, oh, need to get a vaginal culture. I mean, no, this is not our first go-to, but we could be missing 50% of toxic shock syndrome cases. And I just wanted to throw that out there into the universe to get your brain spinning.
Yeah, my eyebrows, went up when we were doing show prep and you asked if I do this because, no, I don't consider this usually. But yeah, we have to get back to that question. First, let's do a quick review of toxic shock syndrome. It is a rare, thankfully, life-threatening complication of certain types of bacterial infections. Toxic shock syndrome results from the toxins produced by Staph aureus bacteria, and the condition can also be produced by group A Streptococcus bacteria as well, so group A strep 2. Menstrual TSS is another flavor of this, and it's generally thought to be caused by when the Staph aureus produces your toxic shock syndrome toxin 1, otherwise known as TSST1, in the patient. 4 factors are thought to be required for the development of the menstrual toxic shock syndrome. Number 1, vaginal colonization with a toxigenic strain of Staph aureus. Number 2, production of that TSST1. 3, penetration of a sufficient concentration of TSST1 across the epithelium to cause a disease. And 4, absence or insufficient titers of any sort of neutralizing antibody to this toxin.
Yeah, so please note, toxic shock is not something that is just left for retained tampons in the vagina. It can also affect anyone, including men, children, postmenopausal women, and risk factors for the syndrome include skin wounds, surgery, and certainly the use of tampons, diaphragms, or even those menstrual cups. So interestingly, as a ped specialist, I found this to be an interesting fact. So toxic shock was first described in a series of pediatric cases in around 1978 in the literature, and the incident rose sharply in 1980. More than 800 cases of menstrual-related TSS occurred largely among young women, and clinical illness arose during menstruation and was associated with the use of absorbent tampons. So the incident of toxic shock declined sharply after the withdrawal of some of these tampon brands. So something was going on there. But subsequently, between 2000 and 2003, the incident rose slightly again. And in one report, almost tripled. So these cases occurred mostly again among women of menstrual age, but included both menstrual and non-menstrual cases. We'll talk a little bit about that in a few minutes. But again, the rise or spike may have been related just to the fact that we had better testing and we were investigating this more. So, we certainly were on the prowl for some of these symptoms.
I'll be looking more for it now too, that you've kind of opened my eyes to it. Here are some symptoms of toxic shock syndrome: a sudden high fever, hypotension, vomiting or diarrhea, a bright red rash on the palms and soles, or a desquamating kind of peeling rash on the palms or soles, confusion, muscle aches, redness of the eyes, mouth, and throat, hopefully not, but seizures, headaches, and there can be other multi-organ disease as well if this toxin is being seeded throughout the bloodstream.
Yeah, so I like to kind of walk our listener always through sort of what we're doing for this patient. So let's say a patient comes in, they have a fever of unknown origin, they're not feeling well, you're not really sure like what their issue is. They're telling you some of these symptoms that Mike just told you. So you're like, okay, maybe I'll get some labs. Lab abnormalities usually reflect some kind of shock or organ failure, right? We're sort of looking for this multi-organ complication. elevated BUN and creatinine, renal failure, elevated liver function, and possibly elevated CPK, possibly other elevated inflammatory response markers. But UpToDate has a nice little table if you want to go check that out. This is really an inflammatory process of what's going on here. So you think to yourself, like, what's actually happening here? It's an inflammatory process. Cultures, including blood cultures, we're saying from the mucosal sites, blood, mucosal, vaginal canal, of course, in suspected menstrual toxic shock, wounds, and even from the nose, they should all be obtained. And the detection of this Staph aureus in the blood culture is not required for the diagnosis of toxic shock, because you know what? Only 5% of the cases, according to the literature, 5% are going to show this in the blood. You're going to find the staph toxin from the wound or the mucosal site or the vaginal area. So any foreign material in the vaginal canal, like we talked about, should be removed immediately. If that's what you're looking for. Of course, certainly that may not be something that someone's telling you when they present to the ER and they're super sick. But the other little pearl, they don't teach you this in school, is that when we have a trauma patient, a female trauma patient, we always, I would say almost always, put in a Foley catheter. And when we're there, we look to see if there's a tampon inserted, and we remove that during, if there's an intubation or the patient is unconscious. So again, one of those job pearls that no one tells you. Make sure you take a look when you're doing your rectal exam that there's no foreign body down there, because if they're going to the ICU, that tampon's going to hang out there for a real long time.
Yeah, I can't say we went over that in our ATLS recertification a few months ago. So that's a
great
They
should. I'm going to do a guest lecture.
They totally should. Yes. No, I'm not totally serious. Let's also talk about this, right? Leukocytosis, like that white blood cell count, okay? That may be absent in these patients. So as far as an absolute leukocytosis, but look at beyond the number of the WBCs. The total number of mature and immature neutrophils usually exceeds 90%, with immature neutrophils accounting for 25 to 50% of the total number of neutrophils. You can also see things like thrombocytopenia and anemia in the first few days, and that's usually accompanied by a prolonged PT and PTT time. So, those coags that are auto-ordered when you're doing a code sepsis, go ahead and leave those PT and PTT checked so you can look for that, because disseminated intravascular coagulation, or DIC, can also be going on.
Right. And you have all your specialists involved at this point. You have a really sick patient, you're involving your physician colleagues, maybe even another nurse practitioner or PA, infectious disease. And we're going to kind of get to that at the end. But also, interesting fact, toxic shock can reoccur. People who have had it once can get it again. And if you've had toxic shock from any prior serious staph or strep infection, you're not going to use tampons. You're going to obviously have patients keep that in their medical history. And again, this can reoccur in days to months after the initial episode. Now, there is also a variant of toxic shock described in patients with AIDS, and this presentation is characterized by a subacute illness with persistent this rash, the desquamation, the mucosal injection, the fever, the hypotension, and again, really shocky-like picture with an inflammatory response. And according to the CDC and UpToDate, a confirmed case of toxic shock is a case that meets the following clinical criteria. And I just really want to put this out there first, because we're going to later try to tell you that you shouldn't use this criteria. So I'm going to tell you that criteria because it is important that you know it, but I'm telling you, you're probably going to miss some cases if you chalk up your diagnosis to meeting all of these criteria. And we'll talk about criteria and guidelines a little later. I keep saying that we're going to talk about things later, but there's just so much information, Mike, it's hard to get to today. So again, they have to meet this criteria for toxic shock: fever, hypotension, diffuse rash or desquamation, and the involvement of at least 3 organ systems, with cultures negative for alternative pathogens or serologic tests negative for other conditions if you obtain them. And a patient who is missing one of the above clinical criteria may be considered as a probable case, but the CDC criteria was established for epidemiologic surveillance and should not be used to exclude a case that is highly suspicious for toxic shock, even if all the criteria is not met. So if you're thinking it, which you may be now more, then you need to pursue it.
Okay. In settings where further lab investigation is feasible, you can do some additional tests that can help you make like a retrospective diagnosis of TSS. Okay. So you can look for Staph aureus isolates and test them for toxin production in research laboratories. So we're kind of going next level on our lab work here. In addition, you can, assess acute and convalescent serum for antibody responses to the various Staph aureus exotoxins like that TSST1 we were talking about here. The presence of a strain of Staph aureus that produces toxin in a patient who does not have acute phase antibody to the toxin is highly suggestive of TSS. Now, treatment for TSS can vary. Antibiotics will have to be diagnosed with infectious disease, but they include coverage for staph and MRSA, and also sometimes IVIG is also used. Remember, this is an inflammatory reaction. Yes, it started with a bacteria, but it produced a toxin, and the body's reacting not just to the bacteria, but to the toxin as well. And so this IVIG you would use with other, similar weird inflammatory type reactions, like Guillain-Barré, that's an option here. How long you would use antibiotics, how long you'd use IVIG is not really settled in the literature here. ID is going to want to be your best friend on this one.
Yeah, I like the single case study coming back to HIV/AIDS patients, and one case report of a 39-year-old male with HIV infection, had diffuse erythema on the arms and legs. He had that desquamation of his arms, hands, feet, and eyebrows. He had some pharyngeal erythema and a lesion that grew out, a TSST1 producing Staph aureus. Okay, he was given IVIG 200 milligrams per kilogram per day. And that was administered for 5 days after he failed antibiotic therapy. So basically, they thought that this IVIG was something that was more useful for him. Again, super complicated, cool topic of treating with IVIG. We do it a lot with kids with Kawasaki's and sometimes now COVID. So just something to keep in the back of your mind.
And it was with the IVIG that this person finally got better, right? It wasn't with the antibiotics, but yeah, the IVIG is what turned him around. So super cool there. Let's talk the downsides. Death associated with TSS usually occurs within the first few days of hospitalization, but it may occur as late as 2 weeks after. When we're talking about why fatalities occur, we can attribute it to things like refractory cardiac arrhythmias, cardiomyopathy, irreversible respiratory failure, and rarely bleeding caused by the coag defects like the DIC we were talking about here. This shock-like picture can kind of help us predict what we could maybe do to treat the patient, prevent these issues if we can.
Yeah. Now, I want to end this particular segment by talking about a little controversy with the CDC guidelines in toxic shock, like I said we would get to. I looked at a recent French April 2021 paper in the Journal of Clinical Infectious Disease entitled menstrual toxic shock syndrome, a French nationwide multi-center retrospective study. And they acknowledge that our literature and study of this topic is basically shit. Okay.
They would say merde in France. Yeah.
Merde. Anyway, this was a multi-center retrospective cohort study of patients with a clinical diagnosis of menstrual. I'm just going to abbreviate it to MTSS here. Menstrual toxic shock syndrome, MTSS. Admitted between January 2005 to December 2020 in 43 French pediatric patients were in the study, and 36 adult patients were in the study in the ICU. And basically their aim, they were doing this study. Great paper, by the way. I very rarely say that. I read a lot of papers. This was a great paper. The aim of the study was to describe the clinical features of short-term prognosis as well as to assess these 2011 CDC diagnostic criteria in critically ill patients with MTSS. And they felt the CDC guidelines missed potentially 48%, half of the TSS patients. Let me tell you, again, absolutely fabulous read. So they looked at this patient population. I'm going to let you take a look at the paper yourself, but essentially, I think it's kind of a reminder that the CDC gives us guidelines, and that basically the disease doesn't always follow the guidelines, so nor should you. I think if you don't have all 5 of these criteria, that doesn't mean that you shouldn't be considering this as a possible issue. So I just wanted to talk a little bit about some additional laboratory criteria that you might want to consider. Don't forget that maybe you want to get a LP, or maybe you want to add on these other weird tests like Rocky Mountain spotted fever, lepto, or measles, or something like that. So, Mike, again, we're going off of the CDC guidelines. So why don't you tell us a little bit of what the CDC guidelines do suggest as a probable case versus what the CDC again says is a confirmed case?
Okay, gotcha. Well, a probable case is a case which meets the laboratory criteria that you kind of mentioned, and which 4 of the 5 clinical criteria described above are present. A confirmed case, which meets the lab criteria and in which all 5 of the clinical criteria described above are present, including desquamation, unless that patient dies before desquamation occurs. So that's one of those things, like if you're lucky, you get to the point where your skin peels off your body. Okay. I think with this, this is a terrible disease. I was actually looking for this in me when I was having my urticaria. I was like, do I have any sort of weird desquamation going on? Am I dying? But, I think this teaches us that these are, again, like you said, guidelines. And diseases don't have to read the textbook before they come into the ED. If you get the feeling that this is something different than just a COVID sepsis, or like, yes, of course, we can't find the infection because it's COVID. There is no bacterial culture growing out of the blood or anywhere else here. Consider this toxic shock syndrome. In that French study you mentioned, at ICU admission, no patient met that 2011 CDC criteria for confirmed MTSS, okay, where 5 criteria have to be met. Only half, 52%, fulfilled the criteria for probable diagnosis, and 48% met only 1 or 2 or 3 of the criteria at ICU admission. And that would not have been categorized. So this is one of those things where you have to get ahead of it. It's not enough to just wait till they're dead and go, oh, look at that. They've got some desquamation going on. I guess they were a toxic shock syndrome patient. You have to kind of anticipate and get ahead of the patient, get ahead of the disease process.
Was that your infectious disease physician impression?
Yeah. Huh. Jesus. Yeah. I guess it was TSS. Oh, well, hey, good one for the papers. Yeah. So, well, and like we said, vaginal samples in these patients were incredibly helpful to make that final diagnosis in this French study.
Right. And, we joke about our specialists. I got to tell you, infectious disease, again, one of my favorite physician groups to work with. And the residents are just so fantastic. They always want to get like this big, long history. And I absolutely love them. So lots of love to you. But again, interesting topic. Good one to brush up on. Otherwise healthy, well-appearing female patients like Kara, like we talked about, with no other symptoms, she can be discharged. You don't need to put her on antibiotics. You don't need multiple vaginal irrigations. I usually tell women, take a bath, clean. Don't sit in the bathtub actually for more than 5 to 8 minutes, which, by the way, is very hard to do for some people. Some people want to sit in there for an hour. But avoid anything in the vagina. And I say these words, nothing in the vagina. That includes penis, foreign body, tampons, or other for a full 2 weeks. And there can be a foul odor present for the next couple of days, but it should improve. And if it doesn't, then they need to go back to GYN, or again, come back to see you if they can. So, we end this segment by saying maybe when we culture and swab everything, we need to consider the pelvis, and vaginal infections like TSS can be possible.
Well, while we're down here talking about foreign bodies in the vagina and toxic shock syndrome, Martha is going to go next now to foreign bodies in the rectum.
Right. So again, difficult topic. Look, treacherous, I will say, but I am sure that you've heard patients say things like, I fell in the shower and that's how I got that there, or possibly they have some other story. But again, being respectful of the fact that, hey, this person's there. How can I help them? This thing is in their hole and I got to get it out, right? It doesn't matter. It's an orifice. There's something in it. You got to get it out. Right.
This can be even more tricky than a retained tampon. That's relatively straightforward. We need to think about the rectum and the anus and how anatomically they're different and can be harder to access. And sometimes you may need a surgeon or a specialist to get into the rectal cavity. Once things go up, it's different than the vagina. The vagina has kind of like a defined endpoint. But once things go up under the rectum, they can go way up into the rectum, and maybe you can't reach it as an ER clinician.
That's right. So again, shout out to our surgeons here because these are difficult cases for them as well. So with that being said, let's talk about this case. This is a case I had years ago. A patient came in for rectal and back pain. That was her complaint. When I spoke to her, she said that it just hurt. It just hurt. She felt like something was up there. She didn't give me any other details. I asked her very difficult questions. And then she said, well, I did use, a vibrator tool to relax her lower back muscles. And then oddly, she felt something sort of pop. So she said to me, sort of popped. I was confused. I tried to ask her again, more specifically, was the vibrator in her rectum? And I actually think that sometimes patients don't realize like what the rectum is. So I said, did you put it up your butt area? Sometimes you just got to use terms that people are more comfortable with. And I got a pelvic exam because she said that she didn't know really where things were. And I said, you know what? Let's just get a quick image. Let's take a quick look with an X-ray. And it wasn't just one, but there were several pieces of vibrator in the rectal cavity.
I've not ever recommended folks use a device like that to relax lumbosacral pain, but something I'll consider now for sure. Okay, well, what did you then?
Jesus Christ. All right. So I went back and I talked to her. I told you guys, maintain professionalism. I'm putting back on my professional face.
I'm just saying I've never considered it. Like it's something to third or fourth line treatment, I suppose.
Look, I laugh about people with broken ankles too. All right. I laugh about everything. But again, be very conscious here. I went back to talk to this patient and she said, well, I guess it fell off and went up there. And we know that's not really possible, Mike, but who cares? The end game is still the same.
It's a better excuse than I fell on it, I suppose, but all right.
Yeah. Okay. I, spoke to one of our on-call surgeons. He said, okay, look, get an anoscope. We looked at the images, try to remove it. And I said, well, there's a couple of pieces. So we used some topical lidocaine, which is totally safe in the rectal area and around the anus we use it for hemorrhoids all the time. She did not tolerate that exam well. And what's, really impossible to do is remove small objects that are broken inside the rectal cavity. So, I thought, look, he needs to come in and maybe use some propofol and a larger anoscope to take a look. And it's just, these patients sometimes need to go to the OR to get things removed.
Yeah, you know what? You mentioned the lidocaine. I love that. So what I've ordered or what I started ordering recently for my rectal exams is the kind of like Urijet lidocaine that is often used in urethral catheterization. I'll have my nurse instill that in the rectum and wait 5 minutes, and then I'll do my rectal exam there. So I love that idea. Yes, totally safe to put lidocaine up in the rectum as well. So, okay, went to the OR. So that patient education, I guess, was done by the surgeon later on, unfortunately, huh?
Yeah, right. So not much education done by me, but I did learn a lot, okay, from this case. This is a good case to have the specialists involved, very respectful. Don't be on the phone out in front of all the nurses saying like, I got this foreign body in the rectum. Everyone's turning their head, like not appropriate, okay? You don't need to announce that. Patients do hear what's going on in the hallway. And I think, there's a lot of things that can go up there. There's fruit, toy cars, light bulbs. We'll talk about a couple case studies in a moment here, but the rectum, again, is a very different procedure. You don't want to cause damage. It's a lot easier to look in the vagina and with a regular pelvic speculum than use an anoscope. It is difficult. And if you're not trained to do that, don't just do that. I mean, it's clearly, I don't need to say that to you all, but sometimes we think, oh, like you said, I'll watch a video and I'll do this. And this is not one of those times. So there's a great article in the World Journal of Emergency Surgery that reminds us entrapped anorectal foreign bodies are being encountered more frequently in clinical practice. Although entrapped foreign bodies are most often related to sexual behavior, they can also be from the result of an ingestion or a sexual assault. So don't forget ingestion as a cause either, which we're going to talk about body packing and body stuffing in just a moment. Looking at this one paper, they looked at 15 patients from 1999 to 2009 with foreign bodies in the rectum. And again, they remind us in the paper, like, be very respectful of these patients. They too were ringing the shame bell. But they had to diagnose these and treat them, and basically information about how these people presented, what was in their treatment strategies, outcomes. They were all documented, and they retrospectively reviewed the medical records of all these unusual patients. All the patients were males. Their mean age was 48, and the objects were things from a body spray can, like the impulse body spray can stuff, a bottle itself, a dildo, an eggplant, a brush, a tea glass, a ballpoint pen, a wishbone. And they found that the wishbone was actually an oral ingestion. But 12 objects were removed transanally by anal dilation under general anesthesia, and these patients required three of them required a laparotomy.
Wow.
And talk about emergent, right? Again, specialists involved, foreign body in the rectum, almost always. Okay. Routine retrosigmoidoscopies were performed after removal to ensure that everything was okay. And they did find some perforations. Okay. There were some lacerations as well. Nobody died, which was great. Although I'm sure that this was probably the most traumatic experience of their life.
What they concluded from this study was that foreign bodies in the rectum should be managed in a well-organized manner. You can start by confirming the diagnosis with plain abdominal radiographs and rectal examination. If you're going to try to manually extract something back there without any anesthesia, as far as general anesthesia, that's really only possible for your very low-lying, inferior presenting objects here. Patients with more higher-lying foreign bodies, they're generally going to require general anesthesia to achieve that complete relaxation that's required to pass this object through the anal sphincters. Okay. Open surgery should only be reserved for patients with perforation, peritonitis, or some sort of an impaction or for the foreign body. So often we can do, more just extraction, PR, if there's none of those things going on.
Yeah. So again, the authors kind of went through a bunch of different things that can be in there. Some of the other things, that you don't really think about, the Christmas ornaments they talked about. I mean, anything can go up there. Okay. Period. Just know that anything can go up there, and the list goes on and on.
I'm worried that they were doing these segments here just to cover some weird internet searches you've done, Martha. But that's okay. We're going to keep going. All right. Patients may complain of vague abdominal pain and not just straight up telling you that this happened, and that's a great topic. It's a great thing to look for with all these different kind of sensitive diagnoses, things like testicular torsion or stuff like that. The presentation is not always just straightforward. Sometimes it's just kind of a vague complaint, and you have to kind of pursue further here. They may not admit to the actual issue. There may be rectal bleeding or urethral bleeding, constipation, lots of things that patients, especially if they're young or otherwise, may be embarrassed, may not be willing to describe up front, even maybe not even just to a triage nurse. You have to kind of get them more to a private area and then talk to them more there. So if you hear this kind of like hesitancy in the discussion when you're in a room with like the triage nurse, the tech getting vital signs, and maybe you kind of go, I can tell this person kind of wants to be a little more private in their discussion, and you pull them aside. Okay. While you're doing the initial exam here, you want to look, if you have your thinking cap on, for something bad inserted in the terms of it's doing something bad, not a judgment call or anything. Signs of infection or perforation that may be evident in your complicated cases just from your initial exam, pain with percussion or rebound tenderness, stuff like that. That rectal exam is going to be essential, of course, in the diagnosis of these rectal foreign bodies, but it should be performed after the X-ray of the abdomen is performed to prevent accidental injury, not just to the patient, but also to you. You're hearing about these things like broken, vibrators, glass objects, things like that. So you don't want to be reaching in there and having to deal with one of the topics we had on a previous podcast with regards to bloodborne illnesses. Okay.
Yeah. Mike, yeah. Sorry, there is one specific case that I saw in the literature of a employee that was doing a rectal exam, a clinician, and there was something sharp in the rectum, and they weren't sure if they stuck their finger or not. So, that call to HR is like, well, I had a patient with a foreign body in the rectum, and I did an exam, and I cut my finger, and I'm not really sure what happened there. I mean, that is just something you don't get to say every day, and we don't want you to have to say it. So get that image first.
Yeah, I love that. Okay, and how about lab evaluation, Martha? Are there labs we need to do here up front?
No, don't waste your time on labs. Unless, of course, these patients are going to go to the OR, then you might want to get a type and screen, maybe a baseline CBC. Again, the images are the key here. And if you can't really see it or it's kind of confusing, you can get a couple of different views. But really just try to determine the body, the foreign body, its positioning, its shape, its size. And then, of course, make sure there's no presence of a pneumoperitoneum in any way.
This is the part where we kind of get into some more unsavory parts, aspects of this that could be going on here. Sometimes these foreign bodies are inserted involuntarily. And sometimes these involuntary insertions can be found in the elderly, but also people who are mentally ill or otherwise infirm, and even children.
Yeah.
Sometimes these objects are retained thermometers or enema tips. Maybe it can be aluminum foil wrapping from pill containers. Maybe there are ingested objects that make their way down, like toothpicks, chicken bones. I've had a patient who was fond of ingesting pieces of plastic, like ballpoint pens, coins and toys, like you mentioned. So keep that in mind as far as elderly patients with constipation, and maybe just something is off about their presentation or how they relate to their caregivers. Consider maybe you get a plain film x-ray at least before just going straight to the disimpaction effort.
Yeah, I had a patient, a pediatric patient, when I worked in rural medicine that would constantly put things in their vagina or their rectum, and they would be in the ER once or twice a week for this. It was they were going through a struggle, absolute struggle, and really just remember that this can be from an assault, and certainly that potentially people could do this for a lot of other reasons related to body stuffing and body packing, which we're going to end our last segment with here. One of the most common types of places to do this is the vagina for body packing and body stuffing, but some people even put these in ostomies. And once they go in the ostomy, it's
wow.
Yeah, there's some interesting things out there. But it doesn't matter whether it's rectal, vaginal, body packing and body stuffing can be deadly. So the Merck manual, I love the Merck manual, has a great write-up to this approach and some fascinating studies in the literature. Body packing is usually heroin or cocaine primarily. That's it. So many other drugs can be used. They smuggle them across the border, and the drugs are basically placed in condoms or packets that are enclosed in several layers of latex or wax. And then these body packers are mules, as they call them. They swallow multiple packets. That's the body stuffing. And then typically they'll take some kind of anti-motility drug to decrease intestinal motility until the packets can be retrieved. Oh, sounds awful. The total amount of drugs involved represents a super lethal dose. So rupture of one of these packets is basically like, you're dead. That's it.
That's terrible. Wow. Well,
Yeah.
obviously, depending on the drug involved, that is going to lead to certain specific symptoms depending on that drug. Some things you may see are intractable seizures, tachycardia, hypertension, hyperthermia. Those are common with cocaine. If we're dealing with heroin, some of the things you may see are coma or respiratory depression here. Obviously, intestinal obstruction, perforation of the intestines, peritonitis. These are also things that you can see.
Yeah. So, usually people will stuff these packets when they're being arrested quickly to dispose of the evidence. So I think really, regardless of whether they swallowed it or they inserted it vaginally, rectally, or within an ostomy, the diagnosis certainly can be tricky. So do that private interview.
And using these terminology, again, with terminology, so stuffing technically is when you're about to be picked up by law enforcement and you quickly swallow the drug packets, or paraphernalia or what have you. Understandably, you're doing this in more of a hurry, and so it may not be as securely packaged as when you're doing body packing, where there's a more deliberate effort to put more amount of stuff in there. And so the stuffing versus the packing, they both have their own kind of risks there. Like you said, doing a private interview, especially if law enforcement happens to be posted in your ER, is going to be, very important to do. Ask about things like a history of doing this before, consider that pelvic or digital rectal examination. Ideally, if we're thinking about something that they're not really disclosing, maybe you get that x-ray beforehand, before you do your digital insertions here.
Yeah. And so let's just kind of end with the fact that if you have a patient that has either staffed or packed, kind of like that term. No, sorry, stuffed or packed, and they're here, and you know that they did that. Really, you have to admit these patients. You have to observe them. You can't just remove the packet. And if they say, "Look, I just have one packet in there, you can take it out." I would not trust that. I get some imaging. I'd watch them because you don't really know. And these people, they could have been pressured or forced, or they could be, again, these abused mules trafficking these drugs. I mean, there's just so many things here at play that I really think you need to investigate them further. And then finally, the asymptomatic people, whether they're being observed or not, get the toxicologists involved early. They love these cases. They're my third shout out physician of the podcast today. I absolutely love them. They're fantastic. They will help you. They will say, well, they're up on the body stuffing and packing. They know how much people are transporting. This is the kind of stuff they look at in their own literature. So, wow, Mike, this was a large, vast amount of information today. We covered everything from urticaria to vaginal foreign body to rectal foreign body. What do we have last here?
All right. This is going to be our first non-medical guest on the Two View podcast. And it's somebody that I've known for quite a long time now. I'd say probably 12 years or so, off and on. And this is retired Army Colonel Kenneth Mintz, known by Kenny to a lot of his people, and you can find him at www.kennywalksacrossamerica.com. And you could probably infer from that website title that Kenny's got a pretty big task coming up. He's planning on April the 1st, and not apparently, as I know, as a big April Fool's joke, but he's really planning on walking across America, coast to coast, east to west, to raise money and awareness for a lot of different causes. Colonel Mintz, Kenny, thank you so much for coming on the Two Views today.
Hey, thanks, Mike. Just one thing. So most of my content is on my Facebook page, which is Kenny Walks Across America. If you go to kennywalksacrossamerica.com, you'll actually go to my shop. You can buy one of these cool T-shirts.
Actually, Kenny, I'm looking at your Facebook page right now, which is actually what really inspired me to have us chat with you today. And I'm looking at all these pictures of Jack.
Yeah, Jack the donkey.
Well, Jack, tell our listeners a little bit about Jack.
Well, I've been training, getting ready to walk across the country. So my goal is to be able to walk 20 miles a day, 6 days a week. And there's a nature trail, the Letort Run Nature Trail, which is near where I live here in Carlisle, Pennsylvania. It's beautiful. And they just opened up an extension not too long ago. And there's a paddock there with this donkey. And, obviously you're kind of curious about this guy. He's sitting there looking at you as you walk by. And I approached his paddock, his little fenced in area, and there was a little sign there that he has a fan page. So he's Jack the Donkey of the Letort or something like that. So I'm like, okay, well, obviously he's whoever owns him is comfortable with us interacting with him. Mm-hmm. And so I just started bringing carrots to him and feeding him. And so now he and I have become pals. And a lot of people actually go out and feed him. So that's a sort of part of my routine. He's my emotional support donkey. Just puts a smile on my face, and he gets very angry at me when I don't feed him. So it's trained me well.
Like any good boyfriend or girlfriend.
Well, our goal is to get you more likes than Jack the Donkey and more awareness than Jack the Donkey here. So, I've come to know you, sir, as a soldier. You're a West Point graduate. You're a retired infantry colonel after 20 plus years of service with multiple overseas deployments. We served together in one of the hottest parts of Afghanistan, kinetic, as we used to say. and that military aspect of your life is a part of why you're walking. But reading what you've written on your walk on your Facebook page, I feel like perhaps you're primarily walking as more of your mother's son. Can you talk more about your mom and how she's inspired you to take on this pretty big challenge?
Yeah. So, I mean, my mom's a big part of it. She's the original inspiration behind this. And I, when I started going through the process of making sure that I knew, why was I doing this? Why did I feel compelled to do it? Sequentially, I started with my mom, then I went to my service, and then I went to myself. So I'll talk a little bit about each of those. So, when I was 4 years old, my parents were separated. My mom was very young when she had me. She was 19, so I'm 4, she's 23. We were in Washington, D.C., Northern Virginia area. And my mom basically wanted to start a new life, and she drove with a Navy family that needed someone to drive a car for them from Washington, D.C. to San Diego. And she had nothing. She had me, a suitcase, and a dream. And, to me, that was always inspiring. And, she got a job. She eventually started her own company with some partners that was pretty successful. And, so that was always an inspiration to me my whole life. And then my mom got pancreatic cancer, and, she was fighting against that cancer for 5.5 years, which is a pretty long time. It's a very deadly cancer, as you probably know, all the way through, 3 bouts of chemo. And then at the end, there was nothing left for her. And I took care of her in her last months of her life. And, when she was in hospice. And, we were already really close anyway, but in these last, sort of years of her life, I talked to her every day, and I spent, the last months of her life with her almost every day. And she, she asked, she knew I told her years ago I was going to do this walk. And she's like, please, raise some money for pancreatic cancer research. So I'll have a link to the charity, all my charities on my social media that I'll start in March with those links. And that the money will flow directly to the charities. And I'll talk a little bit about the service component. So, obviously, I just retired after 34 years from the Army. I wanted to do something different with my life. Watching my mom go through what she went through, and then having to go back and liquidate. You talked about this the other day, liquidate her estate, going through all of her things. And it was obviously very emotional. It was a very tough process, but it sort of gave me an appreciation about, although I loved her home and I loved that it was a meeting place for people, how much stuff we have. And we focus so much on stuff, and less on experiences and living. So, to me, this was a way to be more focused on living my life and less focused on, how much money I could make and then how much is enough there. And, when you're laying in your deathbed, you're not caring about that. You're caring about the people that you're close to, your friends and family. And that's what I care about. So the service component, on the one aspect is an opportunity for me to hopefully get some veterans to come walk with me, because I believe, I think you have a question about this later on, but I think that, a lot of guys feel disconnected and they feel isolated, and that leads to some bad habits.
Right.
And, I want to be a good example and say, let's get out in this world, out in this environment that we don't pay attention to, because we're always in a hurry to get between point A and point B in our lives. And let's just talk and enjoy the camaraderie that was part of our service, and that I believe that shouldn't end. I don't think that, you know, we should like leave service and then, you know, go back to wherever we came from or wherever we want to go as civilians and then become disconnected. It's just not healthy for us.
Yeah, you know, actually, I would like to get right into that, the actual walk when you're out there, and kind of ask some of these basic questions that I think a lot of people have on their mind. What are you going to do about provisions, food, water, clothing? How are you doing this?
Yeah, so I'm taking the lazy man's approach to this. And, you know, in the Army, we have something called the company trains, which is, you know, for an infantry company, you know, it's usually like a vehicle with supplies that's not too far away if you need it. So I'm going to have somebody drive a support vehicle for me. I will have mapped out, you know, where I can stop. And, you know, sometimes I'll stay in a hotel or motel. Sometimes I'll stay at a friend's house. Sometimes I'll stay in a campground. But the vehicle is the ultimate rucksack. You know, hey, bring me a ham sandwich, or hey, bring me some more water, because I'm not going to carry this on my back. That would make this into a survival exercise, and I would become more focused on just getting a meal and where I was going to sleep, and less on, you know, communicating what I'm doing, sharing that experience with people and connecting with people.
Well,
and that's one way you're looking for assistance too, right? Is I think we're still looking for some people to be driving the company trade behind you. Is that correct?
Yes. So it's a big commitment. I mean, I'm probably going to have to try to get, there are some options out there, but I have not. That is the one part of this plan that hasn't been nailed down yet, is getting my drivers aligned. I would prefer to have the same person the whole time, just because I think it would just be, you know, there's a relationship, there's a sort of you know, standard operating procedure that you could sort of establish by working together over a period of time.
Well, you know, thinking about this, you said you're going to do 20 miles a day, 6 days a week, right?
Yes.
So that's 1.2 miles per hour, which we know you're not going to do. You're probably going to do, you know, 5-6 hours at a time walking, and then that's
6 hours a day.
Right. But I'm, you know, you could just constantly be walking for 24 hours, 7 days a week if you wanted to. Which,
yeah, I could. It'd probably kill me.
Yeah, we wouldn't recommend that from our professional health perspective.
Yeah, there's a Stephen King novel about that. It didn't go well at the end, unfortunately.
Yeah. So, but this person that you're looking for to help you, I mean, they're really only doing 20 miles a day. So this is going to be a really short driving experience for them, but a very long time. So like, you know, someone might be thinking, well, how am I going to fill in the rest of that time? But I think there's a lot of directions you could take that. That person could bring on a whole slew of different levels of awareness projects, you know, working remotely, things like that.
Yep. No, you're right. And, you know, obviously it's not going to be like, you know, constantly providing me support. I mean, you know, I don't really need, you know, I need to be able to eat and drink and maybe have an emergency call out for something. But that's, you know, I mean, I'm out here walking around all the time by myself without too much trouble. But, you know, in order for this to work, I really need to have somebody there with support, because at some point, you know, as you go farther and farther west, you know, this country is pretty desolate. You know, you get west of Kansas. I mean, even Kansas is pretty desolate. I'm going through Kansas and then the Colorado down in the southwest, Colorado down through New Mexico, Arizona. It's pretty, you know, there's going to be some long stretches where, you know, I'm probably going to have to sleep on the side of the road someplace.
We need to find somebody who's in telehealth who can just be like working and seeing patients from their car as they drive along with you. It's like nothing lost for them. It'll just be like banging out work, you know, it'd be perfect. Yeah. Okay.
I totally agree. That actually sounds like a great idea.
No, I've got some telehealth folks. I'll make this happen. I'll see what I can do about that. Okay.
I appreciate your help, Mike.
Yeah, that's what I'm here for. All right. Always here for that. Okay. There's healthcare workers are in this pandemic, and I see these similarities between the soldiers that we served alongside with in Afghanistan. We're in healthcare fighting this invisible enemy. It can be harbored in people that we work shoulder to shoulder with, or even the people that we are tasked to serve. There's information wars going on as well. It almost feels like a counterinsurgency fight, and it's a different kind of fight, as you had to learn, than a conventional combat where I can see the thing in front of me clearly. I can see a broken arm in front of me. I can see somebody who's bleeding in front of me. This is a different kind of a fight for a healthcare worker. Are there any best practices for healthcare workers that you think that you can pull from some of these best counterinsurgency practices that you had to learn before, GWAT and the Afghanistan fight that we undertook?
So the first thing I want to say is, I don't have expertise as a healthcare worker, but I certainly am sympathizing with they're the frontline soldiers right now with this pandemic. And some of this is going to be based off of my impressions of things, but I think I'm fairly accurate. So I honor you and I appreciate you. And I think it's important for us as I'll just say us as Americans to let you know that, because I think there's a sense of isolation and frustration and being overworked and overstretched, and not that nobody really cares about them. And there probably isn't a lot of leadership. And I think, frankly, that's the problem. It's a problem in our country, in the private sector and public sector. But where's the leader who's out there actually paying attention to the healthcare professional and checking on them and listening to them? There's difference of opinion about all of this because it got politicized. And so people are now weaponized by some of this. But a good leader at least can listen and care for and provide support to those on the front line. That's probably not really happening. That's probably the exception. So, when we were in Afghanistan fighting a very difficult enemy, a very lethal enemy, I approached that problem and trained our battalion to fight a certain way, and very quickly figured out that wasn't going to work. I had to be honest about it. I had to be honest with myself, because it's not about me. It's about the mission, the people, and then me. So that means humility matters and authenticity matters from a leadership perspective. And if you're wrong, you say you're wrong, because it's not about you. And I now had to make some decisions. Like, do we just keep doing what we're doing and hope that it works out? Or do I say, well, this isn't going to work. I've got to come up with something else. And I decided to change completely how we were doing things. Now I had to convince a bunch of thousands of people, hey, we're going to do something different now. And I had to go around and talk to people every day and explain it every day and listen to the frustration and listen to the ideas. It's leadership.
Kenny, you talk about having a good leader, and a good leader helps people prevent injury and mental crises they might be going through, things like that. I was just thinking to myself, what's going to happen if you get hurt on this trip, or mentally? Who are you going to talk to? Like, I know you're the leader of your one-man band kind of here, but like, it's not though. There's going to be a lot of people following you and watching what you're doing. But what do you do if you get injured or have an issue?
Well, physically, I'm going to be prepared to, if I need to, take a break, or slow down my pace, or just, instead of doing 20 miles a day, I'll do 10 miles a day, or I'll do whatever. It doesn't matter. I'm not an ultra athlete trying to set a world record here. It's about the journey for me. Right. So, if I have to stop for a week and recover because I pulled a hamstring or sprained an ankle or whatever, then that's, I'm not worried about the physical part of it as much. There's the psychological, there's the mental part of it. It's lonely. It can be very lonely, walking out there. I do not plug in when I walk. I do not listen to music. I don't listen to podcasts or anything like that. I just pay attention to my environment. And I always find actually that there is a lot to see. It's
Can you
actually,
tell us a little bit about some of the things you've seen recently besides the donkey? I mean, I know what you've seen because I follow your page, but a
yeah,
couple things. Just tell us that maybe I'm a hiker, so
yeah.
I understand you can go for an hour and you're like, oh my gosh, I've gone for an hour, and I'm not listening to music either. So
Well, I mean, it's going to sound sort of, there's a certain zen to this. I mean, obviously when you're hiking in the woods, that's a different experience because you're really very closely related to nature, and you're looking for things. You're looking for birds and animals and tracks, and you're listening to the wind in the trees. All of those things, every little thing I find an appreciation for. The sound of water rushing and the sound of the wind that I, would not be necessarily pay attention to before. But a lot of the times I'm walking in an urban area.
all right.
And so, it's literally like even here in Carlisle, every time I walk around in Carlisle, I see something new. I see something I've never seen before. And it's just this sort of being in the moment, and paying attention to the world, that enables us to actually see that we live in a really amazing, life if we pay attention to it.
Mm-hmm.
And I'm also a keen observer of the people around me. I mean, I'm blessed because, here I am, I've retired, financially, I'm stable, and I don't have to worry about, I don't feel compelled to have a job to make a lot of money, and I can enjoy my life. But the people around me are in a hurry. Everyone's in a hurry. People driving are angry. I can see it in their eyes. They
Yeah.
pissed off just stopping for an extra second to let me cross the street. I mean,
Oh, dang.
everybody's angry. Everyone's in a hurry.
Well, listen, if for some reason one of those angry people, tries to mess with you, you let me know their license plate. But also, Mike and I were talking about supporting you. If you needed to phone a friend, maybe you got a bellyache for 2 days and you're not really sure why, but that might just be because you've been really engaging your abdominal muscles, for whatever reason. But we're more than happy to be your phone, a medical friend, and I guarantee you there'll be plenty of other people that would love to help you. So just keep that in mind.
No, I mean that's a different layer of connection. Somebody recently asked me how do I define success for this? Is it just getting to California, which is going to be success for you? Well, no, that's part of it, obviously, but it's being able to meet people. It's being able to walk with people or talk to people that just, that I don't even know, who just want to come out and just do something different. And, I'm certainly going to run into things that I can't, medically potentially, that I just can't predict. And, who knows what I'll be eating and drinking out there. There's going to be some challenges there, and I appreciate any kind of support I'm humbled by it, frankly, that people would want to give to me.
Well, I know some people are kind of signing off Facebook to like TikTok or Instagram now, but I encourage you guys, if for nothing else, get back on Facebook so you can follow the journey of Kenny Mintz here. Right now, he's at Kenny Walks is the name of your group on Facebook, KENNY space Walks, WALKS. The website is KennyWalksAcrossAmerica.com. Are there any other good ways for people to kind of watch, follow, support you, things like that, Kenny?
Right. So again, here I am, a bit of a Luddite in the social media. I could definitely use a social media consigliere. So I have a Facebook account, which is Kenny Walks, but my page is Kenny Walks Across America. That's where all my content is posted. So you just have to follow and like that page. I do have a Kenny Walks Across America Instagram.
Nice.
Yep, saw that.
I'm not going to do like funny, TikTok music videos and, light myself on fire
Please don't.
to try to become, some kind of, influencer. Those are the two main places. I have a group, Kenny Walks Across America group as well. I just haven't started playing with it yet. So it's if you go to Kenny Walks Across America, you're going to find me.
Well, we will make sure that we put that in our liner notes. And
yes,
also, I plan to come and meet you in California when you make it here.
Good.
You're not that far away from me. I say that, but California is a big state.
It's a very big state.
I'm going to find a way to get down there and meet you. And your start date is my birthday.
Oh.
So I'm super excited about
Cool.
that. And, we're just really glad we could have you on the show. If any of our listeners would like to reach out, reach out to Kenny directly or let us know. We'd love to continue to support you.
Thank you. If I could, just two more things real quick.
Yeah.
I'm going to be supporting 3 charities, one for pancreatic cancer research. I'll also be supporting an organization called Operation Resiliency, which hosts unit level reunions for veterans. So that's a great way for veterans to connect. I participated in one, so I believe in them. It's through something called the Independence Fund. And I'll also be fundraising for a college fund in the name of Jordan Morris, who was one of the soldiers killed during our deployment. He's going to be, I'm using his name to represent all of our fallen because I think he's a very unique individual. And I describe all of this in my mission statement. But I'll be, all those charities will be up on my Kenny Walks Across America Facebook page. And again, I just, I appreciate the support. I appreciate the interest in my mission.
Of course, you're an interesting guy always, Kenny. We're going to have links to pancan.org. That's the Pancreatic Cancer Education Organization, Operation Resiliency. And man, if nothing else, you guys got to learn about Jordan Morris and just the path that this soldier's life took and how he met his untimely end in Afghanistan, unfortunately. But it's a crazy situation here, and I think you describe it very eloquently. And I think it's great you're raising money for all these education and awareness funds, Kenny. Thank you so much for being here.
Hey, thanks for having me.
Thanks, Kenny.
Okay, for something sweet this episode, we're going to talk about something not so sweet, frankly, and it's kind of where we're at in terms of COVID and therapeutics. Of course, at the speed of COVID, we should have known right after we released our segment on COVID therapeutics last episode, things kind of changed in the world of COVID-19. I had talked back then about, hey, in a pinch, why don't you go ahead and use your BAM-EDI or your CAS-MD, the Regeneron therapeutic antibody cocktails if you have somebody, even though Omicron is predominating right now. Of course, shortly after that, we had a release from the NIH basically saying, hey, we are stopping the use of both of those antibody cocktails in the United States. For now, you can only use sotrovimab. So hopefully you guys have seen that. We will put a link to that kind of notification in the show notes here saying, hey, don't use those things. And so as an amendment to what I said last episode here, I definitely could not, suggest in good conscience here publicly to say, yes, use those, even though the NIH is saying do not use those. So don't use those for now. All right. Talking about Paxlovid, talking about molnupiravir, I'm hoping that in March we're going to see a lot more of these as far as in stock and in more pharmacies. What I found was this very cool website by the Department of Health and Human Services, and it is like a Google Maps for COVID therapeutics. You can find Paxlovid, you can find molnupiravir. We didn't even talk about Evusheld, which is kind of like a pre-exposure prophylaxis drug you give intramuscularly here. But you can find all 3 of those medications, and you just kind of put in the state, and you put in which of the 3 medications you want, and it'll help you graphically find these medications in your local area. So super helpful here. We'll put a link to that graphical device in the show notes here. What else to talk about with regards to therapeutics? Those are the big things, really, is just knowing how to find your therapeutics. And I feel like from my position where I've been having to find these therapeutics, it's becoming easier, thankfully. I was actually featured in the Wall Street Journal recently as far as being interviewed about how hard it was to find the therapeutics. And so as fast as COVID moves, of course, right after that article came out in the journal, this website got publicized with the terms of how to find the therapeutics. And my little something wheat story, if I have to have a something wheat story, it's this. I had a very hard time finding the medication for a person 1 week. I had to leave it to the patient to find their anti-COVID therapeutic. They finally found it. They told me where it was, and I prescribed it. A week later on, the patient's wife came in, and they were having COVID-19. By then, I had found out about this therapeutic website, and first time search, I found the exact one that spouse needed, and they were off to the races going to the exact pharmacy minutes later than that. So this website is really changing the game in terms of making it easier for clinicians to find our COVID therapeutics. That will be in the show notes. It is a very long website. It starts out with COVID-19-therapeutics-locator. It is an HHS website, even though it's on a .com domain. So that's the one we're looking for here if you're just trying to Google it on your own and find it. But we'll have the link in the show notes. We've been remiss to not say our website name. That is 2view.fireside.fm. That is always the number 2view.fireside.fm. All of our show notes for this and other episodes will be at that website. Let's go on to our 2View trivia answer. And right, first, the question and the giveaway.
Wait. We got to tell them what they win first.
Oh, yeah. Go.
This month, we're giving away 20% off the July boot camp course. Okay. And then you're also going to come have lunch with us. We have a really good time. And you can join us in Las Vegas and share your ER experience with us over a good meal. Or if you feel like you're not ready to travel, then certainly we can give you 20% off a home study course.
Here's last month's question and answer. The question: what popular idiom involves what facial body part and a grindstone? And how did it originate? Again, it was what body part and how did the idiom come about? Martha, what's the answer here?
So the answer here is nose to the grindstone. Okay, that's our answer, nose to the grindstone. So when sharpening blades, knife grinders tend to bend over the grindstone or even flat down next to it with their faces near the grindstone in order to hold the blade against the stone. And earliest known reference was from John Firth's A Mirror or Glass to Know Thyself, 1532, where he says, "This text holdeth their noses to so hard to the grindstone that it can disfigureth their faces." So I just thought that this was kind of a cool little throwback to some old literature. And basically, you need to work your face off when you're putting your nose to the grindstone.
That's great. And the winner of that was Kate Van Arman, a nurse practitioner here. So congratulations to Kate Van Arman. We hope to see you in Vegas or remotely pretty soon. Okay.
All right. This month's question, you want to read it or you want me to?
I want to, because this is when I find out, and I'm always excited about, this sort of thing here. Not mushrooms, but video games. We'll be talking about mushrooms on our next podcast. So this is kind of like a teaser and a amuse-bouche, if you will, for our next episode here. This is the two-part trivia question. There's always two parts to our trivia. There is a famous video game out there that involves taking mushrooms to grow bigger in size. What is the name of this video game? And what real-life psychoactive mushroom that can cause users to perceive changes in size of things around them do these red and white spotted mushrooms in the video game look like in real life? Email us your guesses at 2viewcast@gmail.com. It's always the number 2viewcast@gmail.com. And also tell us if you want to give a shout out to somebody as well.
I can't wait to talk about some mushroom stuff.
It can't be more sensitive than talking about foreign bodies in the rectum and vagina. That's for sure.
Oh, and it's kind of hard to get a mushroom up anywhere because it kind of just disintegrates. So don't worry. That's not how we're ingesting the mushrooms.
There will not be a mashup. Yes.
We will eat them. Not us, but the proverbial we. Anyway, so Mike, we got to go. We got to go. For more information about us and our faculty, visit our website featuring all our upcoming courses, www.ccme.org, and consider coming to see us this July. Check out all of our home study courses, Farm, Heart, EKG, Imaging Boot Camps. Check them all out.
Well, thank you for listening to this episode of The Two View. You can subscribe and especially rate us on Apple, iTunes Podcasts, Google Podcasts, and Spotify. Search for Two View Emergency. That's the number 2 View Emergency, and it'll come right up. Ratings help us climb the charts so that other clinicians can get some more Two View goodness. If you like YouTube and you want to see the video blog instead, search for Center for Medical Education, and you can catch the video version. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That's twoview.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on The Two View. Have a great day and a great shift.